Okay, we are on part two now. This is newborn nutrition. Topics for discussion. We're going to talk about breastfeeding, supplementing, when to and how to and why to, pumping and storage of breast milk, and formula feeding. So I love this picture because this baby has almost a perfect latch. You can see his nose touches mom's breast. He's positioned so that his head and body are perfectly in line, tummy to tummy with mom. He's got a wide open, gaping mouth. And he's got his mouth flanged around the areola and not just the nipple. So that is the perfect latch. And I kept it there. Um, so, a few things about breastfeeding. We start out with colostrum, and people love to call this liquid gold because it is yellowish in color and it is so important for the baby to receive, if at all possible. It is low in volume. This is where mom goes, I don't have enough. I don't think I'm making enough. He's not getting anything. But babies have stomachs the size of a marble on that very first day. And it is packed with nutrients and immune factors. It is very, very high in everything the baby needs and low in everything the baby does not. Babies have plenty of fluid volume on board. That's why they lose weight. They have excess fluid from mom at birth, and they lose 5 to 10% of their body weight normally, and it's fine. Um, what we want to know about colostrum is that because it's low in volume, baby will feed more frequently. And that's important because that frequent nursing stimulates the release of prolactin, and prolactin helps establish a milk supply. Whoops, I made a mistake on that. But anyway, supply and demand. It is a supply and demand principle. The more you nurse, the more milk your body makes. So people who start supplementing right away with formula are going to make less milk. People who nurse less frequently and for shorter periods of time are going to make less milk. People who pump more will make more milk. What you really want to do is let a healthy baby regulate that milk supply, and feed on demand, recognizing cues. Mature milk comes in about 3 to 4 days after delivery. And mom, you'll know this because mom will start to feel fuller and heavier if you palpate the breasts. So they'll feel like they're much fuller, and a little firmer. Hopefully, they're not hard and engorged, but they will feel heavier. The milk is white and creamy in consistency. There is more volume to it. Swallowing becomes more obvious. The kid's almost going gulp, 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 to keep up with the increased supply. And this little blurb here where cream rises to the top, this is where you want to educate moms. Mature milk has foremilk and hind milk. Foremilk is like skim milk. It's like watery and kind of bluish. And then hind milk is like the cream. And it might look a little yellow tinged or creamy colored, and it's fatty. But if you put it in a bottle, it separates because it's not homogenized. It didn't come from the grocery store. So people might look at that and think that it's gone bad. Don't throw it out. It's supposed to look that way, but that's mature milk. When to breastfeed, 8 or more in 24. Be a cheerleader. Write it on your whiteboards. Make sure mom knows. Keep track of feedings. Every time you go in the room, did you feed the baby again? Did you feed? And they get tired of being nagged. But if you give them a paper to write that down on, it makes your job a whole lot easier because sometimes moms don't remember. Babies need to nurse at least 8 times, and 8 times effectively, not 8 times of like sucking for a minute or 2 minutes. And sometimes you need to educate parents about this. So I've had a lot of parents go, he doesn't want it. He doesn't want it. He's not hungry. He won't nurse. He's done. And then you look and they've got a pacifier in their mouths, or they've got, they're sucking on something else. And you're like, well, maybe he wasn't done. Let's try again. How long did you nurse? 2 minutes. No, well, let's try again. So 8 or more effective feedings in 24 hours at least, more if possible, and that's fine. Now, you may need to wake a sleepy baby. If they're going like 4 hours and they haven't nursed, you might want to wake them up, change their diaper, even if it's clean and dry, use a cold, wet wipe, get them aggravated a little bit, strip them down, put them with mom, teach mom to tickle their feet a little bit. But some babies will cluster feed and then go one long stretch of like 3 to 4 hours. So watch the baby, not the clock. 8 or more in 24. Make sure that the baby's giving you cues that he's satisfied, or she. I say he because I know that mom is usually she. Um, we can talk a little bit about the needs of transgender men, but we kind of brought that up in a previous video. So I'll touch on it briefly. But if I call the baby he, it's not like I don't want the girls to breastfeed. They should all breastfeed. Growth spurts. Mom should be aware of this before she leaves the hospital because she'll get into a pattern where maybe the baby's feeding every 2 to 3 hours. And then all of a sudden, the baby wants to nurse, 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 nurse. And the baby is nursing 14 times instead of 8 times in 24 hours. And that lasts a day or two. She should know it's temporary. It does not mean that she's not making enough milk. It means the baby is growing. And as the baby grows, nature takes care of things. He's going to suckle a little bit more frequently, be a little bit longer at the breast, be hungrier. And then the milk supply in a day or two catches up and the volume increases. And now the baby's satisfied with the amount that he or she's getting. We advise exclusive breastfeeding in the hospital unless it's medically indicated to supplement. And medically indicated means decided by the pediatrician after looking at all the relevant data. Is the baby losing too much weight, more than that 10%? Is the baby not voiding, not stooling? Is the baby getting jaundiced? Does the baby have sugar issues? In the absence of any of that, we really want to encourage exclusive breastfeeding. And if at all possible, some moms will prefer pumping and feeding, but if at all possible, we prefer to get that feeding done at the breast. A baby is a much more efficient way of getting milk out of a breast than a pump. So that is that. How to do it. These are all the different holds. And we've kind of touched on Latch in one of our prior videos when we talked about postpartum education. So let's talk about Latch again just a little bit. Wide open flange lips over the areola, not just on the tip of the nipple. The tongue should be sort of over the lips and gums. They shouldn't be sucking on the tongue. They shouldn't be gumming the breast. This is sometimes where it's helpful to get a look in the baby's mouth and see if there's a tongue tie, feel the palate, see if that's okay. If mom has a good latch, she'll probably feel like that toe curling sensation for a few seconds, but then once the baby's on and sucking appropriately, if it's a good latch, it should not be excruciatingly painful. It will just feel like a strong tug. And that goes away after a week or so as mom gets used to the sensation of nursing. Good breastfeeding is also about positioning. The baby should not have to turn his head towards the breast. That makes things a lot more difficult. So you see we've got these holds, and you see that the baby is totally in line, tummy to tummy, nose to chest. This is the cradle position where mom sort of has baby's head and the crook of the elbow. What I would do to improve this latch is that I would have mom take this other hand that's not cradling the baby and support the breast in like a C hold with a thumb on top. The cross cradle hold is if she took this arm and took the other arm and sort of had it behind the baby. That's useful if you're going from a football hold to, so silly. If you're going from a football hold and you want to change breasts, you can just take your football hold and move it over to the other breast, and now you're in a cross cradle position. In that case, mom would support her breast like a U with her thumb and forefinger sort of underneath the breast, like where the thumb and forefinger meets, that little like webbing kind of thing underneath the breast, and kind of support it for the baby. And I can demonstrate those with a little pin cushion in class. The laid back position I don't use too common, but if mom has a very forceful letdown, sometimes this is helpful. And this is with mom laying reclined and the baby sort of laying on top of her. And that is helpful when you have sort of an over aggressive letdown and the baby sputters and chokes when they get that first bit of milk. But it's sort of limited to that application in most cases. Sideline position is one that gives mom some rest, and a lot of lactation consultants love it. I like it if mom is awake and alert and there's somebody in there with her. If she's going to fall asleep and that baby's going to roll off her bed, I'm not as happy with it. Because now, or, even if he doesn't roll off the bed, now you're on an adult bed. It's not as firm a surface as a crib mattress. So side-lying, really, you just have to give mom some caution with that. It takes patience. Babies have to learn. Moms have to learn. It's frustrating in the beginning. You think it's natural. You see other animals do it. Human babies are born kind of silly that way. They don't take to it as easily as other animals. So just encourage mom that the problems you encounter in the first couple of weeks of breastfeeding, they go away really quick. And then it becomes much easier than formula feeding, much easier than pumping and bottle feeding. All you have to do really is lift your shirt, hold your baby, and they kind of find it themselves. But that takes a couple of weeks. It doesn't happen right away. We also tell mom, let the baby finish on one side completely. Don't look at the clock and go, okay, it's been 10 minutes. I'm going to switch now. Because if you do that, we don't know how long it takes any given baby to empty any given breast. So we want them to receive all the milk that they can from that one side. At first, they're going to get foremilk, and you'll see it like babies gulp, 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 gulp. They get a lot of letdown with the foremilk. That's that watery skim milk. That has a lot of fluids, and that'll keep them from getting dehydrated. What it does not have is a lot of fat and calories, and that's what the hind milk is for. And the hind milk is at the end of the feeding. So if they finish on one breast, whether that takes them 10 minutes, 20 minutes, 40 minutes, let them finish all on one breast before you burp them and then switch the other side, which they may or may not take. Then for the next feeding, you would start on the side, the opposite side. Whatever was your second side is now your first side. So that's what we tell moms. In terms of burping with a breastfed baby, I'm going to demonstrate burping in class with a doll so I can show you all the different burping positions. But in terms of burping with a breastfed baby, it may not be a very dramatic belch the way you hear in formula babies. They're not swallowing as much air, but still try to burp them. You probably feel a bubble kind of come up. Supplementation of breastfeeding usually is not necessary. If you let a healthy baby regulate mom's milk supply and you don't give it anything else, usually things will work out. However, sometimes we do need to supplement. So the question that a lot of moms ask, and the reason that a lot of supplementation in the hospital happens, is that they don't trust their bodies and they go, how do I know my baby's getting enough? I don't think I have anything. He's not getting anything. They get very freaked out about the fact that they can't measure it. It doesn't look like there's a lot coming out. It doesn't sound like the baby's swallowing. Their breasts don't feel full in the beginning. So what I like to tell them is, look, we're going to be monitoring your baby frequently. We're going to be looking at diapers. Today, your baby needs one wet and one dirty diaper. Tomorrow, 2 wet and 2 dirty diapers. If your baby has that kind of output, then I'm not concerned, and neither should you be. We're going to weigh your baby every day. If your baby loses too much weight, then the doctor may recommend supplementation. But if they stay in that 5 to 10% range, then we're not concerned, and you should continue to breastfeed. Your baby will grow better on your milk. And then you can look for satiety cues. Now, some babies are more fussy than others, and they'll settle down more, and some babies are sort of more complacent, happy to starve kids. Not many, but some. But most babies will fall in that middle range. And when they're done with the feeding, they look satisfied and they go to sleep. And that tells you that they got enough to eat. In the event that we have jaundice, which is excessive bilirubin in the blood, we learn about that at newborn at risk. If we have low sugars, we've got a baby who's too small, too big, infant of a diabetic mother, or late preterm baby, and we're checking sugars and those sugars keep going low, the doctor may order a supplement. Or if we have that excessive weight loss, as I said. Now, there are 2 ways that you can supplement, or 2 types of food that you can offer a baby who needs supplementation. If mom is able to express breast milk and maybe that baby just doesn't effectively express it for her, you can give her own expressed breast milk. You can give donor milk if that's available, an option at your hospital for a well baby. My hospital does offer that. We have it as Metalac. It's a pasteurized breast milk, and people can opt for that. Or you can give formula. That would be your least preferred choice. But if you have to supplement that baby and the other options are not there for you, you can give formula. You should get an order for that formula with the amount and type specified and treat it like a medication. And generally what we will do is offer the breast first, let the baby try to breastfeed, and then we'll offer the supplement after. That way the breast is still getting stimulation. Eventually mom will catch up. And we have mom pump. If mom is supplementing, if she's not making enough milk for this baby, then she needs to pump to increase her supply and demand. Um, a supplement does not have to be offered in a bottle. It can be offered in a spoon or a cup or a syringe or a bottle if we want that. If we do give a bottle, we want to make sure we're using a slow flow nipple and we're using good techniques, which I'll talk about more with formula feeding. There's also something called an SNS or supplemental nursing system, and it's sort of like a bottle that hangs around the mom's neck. It's got like a little strap, and then instead of a nipple, it's got two tubes that you tape to mom's breasts, and the baby latches to the breast and gets their supplementation that way. So if that's an option for you, you can use it. In terms of pumping and storage, so this is your hospital grade pump. Now, if you see a product here that has a brand, I am not endorsing. I don't get paid to push Medela over, any other model of breast pump. It's just what I found on the internet and posted on this slide. Um, but sometimes we'll have moms pump with this hospital grade electric pump. It's a double pump, so she can pump on both sides. We might start that if a mom requests it. Maybe she knows that she's got 3 kids and always she needed to pump to get her milk supply started, or she just wants it. If baby is separated from mom for whatever reason, let's say mom's in the ICU or mom's baby's in NICU, we can get mom to pump so that the baby still has her breast milk and she protects her milk supply. And anytime we have a need for increased stimulation or supply, we can use a pump. Um, a few things about beginning pumping. Setting a pump up is not really that difficult once you know your model. It's really not hard. The big things are you want to make sure that mom has supplies to clean out all of those little pieces so that we don't create any kind of bacteria growth inside those pieces. We want to, teach her how all the parts fit together. We want to teach her how to use the pump. But most importantly, we want to teach her that the first few times you pump, you're probably not going to see anything. And that's okay. That does not mean that your baby was starving. It's not proof that you don't make milk. It's just that a pump is never as efficient as a baby. There is also a psychological component to breastfeeding. Letdown can be triggered by hearing other babies cry or by smelling your baby's clothing, or some people will have milk let down when they smell Dreft laundry detergent. There is some sort of primitive psychological component to that, which a pump will not elicit. So it's kind of normal in the beginning. Eventually, that stimulation will catch up and the milk will be expressed. In the beginning, the amounts are never as much as a baby would get. Just make sure that mom is aware of that. In terms of storage, I am going by what your book says. You will see different lengths of time listed in different resources. Go with whatever your hospital lactation department is suggesting. But your book says that breast milk is good if we haven't frozen it or done anything to it in the refrigerator for 8 days. I would give it a sniff test personally after a couple days. But that is what the book is citing as the length of time it can be good. The freezer, 3 months, and that is like I would put it in the back of the freezer, not in the door. If you put it in the door, where I put like hot dog rolls and loaves of bread and stuff like that, it's only good for 1 or 2 weeks. If you freeze it and then thaw it in the refrigerator, it is good for 24 hours. In terms of rewarming frozen breast milk or even refrigerated breast milk, do it in a container of warm water or under running water, even you can do it. Do not use a microwave. Some people have fancy bottle warmers, and that's okay. Just make sure you test the formula. The breast milk temperature on your wrist before you give it. Teach mom to do that. You're not going to be doing that for someone else's kid, but anyway. No microwaves and no stovetops. Don't put the breast milk in a pot full of boiling water. It's just not safe. It can heat unevenly, it can burn your baby, and it destroys some of the heat-sensitive components in the milk that are so good for immune factors. Now we're going to talk about formula feeding. Why would moms formula feed? Well, there's a lot of reasons. Some moms just have a preference. They do not want to breastfeed. Either they have breastfed in the past and been unsuccessful, or they have decided that this is just not for them for whatever reason. And we support that as long as mom has been educated to understand the risks of giving formula or the risks of not breastfeeding. Um, but if mom has indicated a preference that she is going to give formula, then we allow that. We just help her to do it safely. Other reasons, some maternal medications are incompatible with breast milk, and that is a decision that should be made with the pediatrician and a lactation consultant. Many maternal medications are safe to take with breastfeeding. And certainly the stuff that we give in the hospital, Colace, ibuprofen, even Percocet, is safe for breastfeeding. It transfers in very small amounts or not at all. Mom may have to, or the baby may have to get formula if it's separated, especially if it's a long-term separation. For example, when you have child protective services involvement and mom's not around to give breast milk, or if say mom's in the ICU and she's, not able to pump or feed. These would be some reasons to give formula. Maternal HIV, certainly a reason not to give breast milk. It is transmitted through breastfeeding. So we would advocate for formula feeding in that instance. And then there are some neonatal metabolic disorders, and you won't know about them in the hospital necessarily because they're part of that state screening. But galactosemia is one of them. PKU, you can breastfeed to a limited amount, but you need to test the phenylalanine levels in the baby's blood. And you can't fully breastfeed, is my understanding, with PKU because breast milk has a lot of phenylalanine in it and they can't break it down. Risks of formula feeding. So these are the things we want to educate mom about. So some of them are risks of formula feeding specific to getting a foreign protein. Some of them are risks that are associated with not giving breast milk. So allergies are more common in formula fed babies. They can be allergic not only to the formula, and they can be allergic to many types of formula, but they can develop other allergies later in life because they did not receive those immune factors and they were exposed very young to foreign proteins in cow's milk or soy or whatever type of formula you're using. There is an alteration in gut flora. Formula promotes the growth of different types of bacteria in the baby's intestine than breast milk does. Breast milk has a lot of good probiotics that promote the development of healthy gut flora. And a lot of our health that's being found out is related to our microbiome. So that's sort of a big thing. There's a risk of overfeeding because people want to give. They want to give as much formula as the baby will take. And babies have an inborn need to suck. So they'll keep sucking on that bottle, sometimes even if they're puking up extra formula. So there's a risk of overfeeding. Especially in families that equate fat babies with healthy babies. And there's also an increased risk of ear infections, respiratory infections, asthma, later obesity, and eczema. Um, and those are some risks of formula feeding. Mom should just have informed consent before she does it. That's all. We're not there to argue. We're just there to inform. Formula feeding, what to feed. Usually it's milk based. Sometimes it's soy or lactose free or pre-digested formula. That would be a special needs thing and it would be determined by the pediatrician. But we usually start them off. Brands don't really matter. Enfamil, Similac, Good Start. I mean, sometimes there's a digestibility factor involved. Sam's Choice if you go to Walmart. But nutritionally speaking, they all have to meet the same standards in terms of nutritional content. So that is what you would feed. When to feed 6 to 8 times in 24 hours. It works out to roughly every 3 to 4 hours. It does take longer to digest. Sometimes that's, important if you have a baby with sugar issues. Sometimes the formula might stay with them a little bit longer. Don't tell any lactation consultants that I said that. But anyway, 6 to 8 times in 24 hours. How to feed? Well, if you aren't using the ready to feed bottles that come in the hospital, you need to make sure that you understand the instructions. They are listed on the container. If it's powdered, it should usually be like I'm not testing on this, but just know it's 1 scoop to 2 ounces of water. Make sure that you're measuring the water in a watering cup. Fill the nipple of the bottle with the formula so that there's no air. They're not sucking in huge amounts of air with that formula. Hold the infant en face and use it as a bonding experience when you're feeding that baby. Never prop a bottle, never leave a baby alone in a crib with a bottle, don't put them to sleep with a bottle. Burp them halfway through the feeding and at the end. They suck in a lot of air, these kids. So they really need that burp to stay away from being colicky. We don't want to heat formula in a microwave or on a stovetop. As I said, it can heat unevenly, it can overheat. We don't want to burn any babies. And also, if you heat a bottle in the microwave with the nipple on it, it's going to explode. So don't do that. Once the baby starts to nurse from a bottle of formula, anything they don't eat within that hour needs to be thrown away. And if you're mixing water and powder to make formula, it's good for 24 hours in the fridge once it's mixed. And then again, 1 hour after they start sucking on that bottle. There's also liquid concentrate, has to be diluted properly. And then there is a ready to feed canned formula, comes in a quart, and they kind of look the same. So just make sure that parents know that whatever kind they buy, they need to read the instructions on the can. And now we are at the end of this video. And I will start the